Welcome all to our May edition of the TB Think Tank webinar series. This session is titled TB and Nutrition in South Africa, World Health Organization's latest guidance and why it matters now. A brief introduction to today's speakers. We have Nkateko Mkhondo, who is a medical doctor and public health specialist, currently serving as a technical officer for tuberculosis at the World Health Organization country office. In this role, she supports national TB efforts by generating evidence through research, developing normative guidance, and adapting global best practices to local contexts. Dr. Mkhondo has provided technical leadership in priority TB studies and program reviews across several countries. She brings extensive clinical and public health experience in TB and HIV, with a career spanning the public sector and NGOs, both locally and internationally. We also have Annabel Baddeley, who's a technical officer working in the People-Centered Services, Communities and Determinant Unit at World Health Organization Global Program on Tuberculosis and Lung Health in Geneva, where she's been working since 2010. Her work focuses primarily on the development of normative guidance on TB, HIV, and comorbidities, global monitoring and evaluation, and on support to countries in the scale-up of policy on integrated care and prevention for TB comorbidities and health risk factors. Prior to World Health Organization, she worked on TB and primary health care with the British non-NGO Merlin in Russia, Kenya, and the DRC. I will now hand over to our presenters.
Thank you so much, Nolazi. Just give me a second to share my slides. Okay. Please confirm that you can see the slides.
I think in a few when you put in presentation mode. Thanks. Yes, we can. You may go ahead.
Okay, perfect. Good afternoon, colleagues. So as already introduced, I'm Nkateko Mkhondo. I'm in the WHO country office here in South Africa, and I will just be giving sort of an overview of TB and nutrition in South Africa and basically setting the scene ahead of Annabel's presentation, which will then take us into the WHO guidance. And I think after that, probably we can sort of have discussions on how do we practically improve this going forward. This is just an overview of my presentation. I'll just start with the nutrition status in South Africa, look at how it's impacting TB outcomes, then go into current interventions that are currently being implemented, as well as the importance of a multi-sectoral approach as we move forward. So I won't really go into the numbers. I think that they tell the story themselves, but just to note that in South Africa, we have seen a reduction in TB incidence from 2015, which is the baseline for the NTB strategy. So we've exceeded our 2025 target of 50%. So we've really done well with reducing incidence. However, TB deaths have only declined by 16%. Falling far short of the 2025 target of 75%. So mortality is still currently a challenge. We have one death every 9 minutes. And I think this discussion is also quite key because nutrition does play a role in TB outcomes. That said, in the Global TB Report for 2024, which lists some of the risk factors that contribute to TB. In South Africa, yes, HIV is the leading risk factor, followed by alcohol use disorder, smoking, diabetes, and undernutrition. So undernutrition is definitely one of the leading TB determinants. And in fact, globally, it is the leading determinant, then followed by alcohol use disorder, smoking, HIV, and diabetes. So for South Africa, it looks a bit different, but just to say that it is still a determinant that we need to address. Okay, if you look at the map on the right side of the screen, you will see that our continent, and I guess part of Asia, is quite significantly affected by the prevalence of low BMI among adults, or among people rather aged above 18. So for South Africa, a national picture, we are sitting at 5.2% as of the 2022 data from the World Bank. However, if we look specifically at TB patients, there's a nice study that was done at Standerton TB Hospital, which found that 51% of the patients had a BMI of less than 18.5. And in fact, 70% had a high risk of malnutrition when using the MUST tool. We also have a challenge with childhood stunting at 29% for children under 5, as well as child wasting. So if we zoom into, I guess, some of the data that we have in the country, starting with the TB patient cost survey, in this survey, we found that almost 26% of the participants had a low BMI, less than 18.5. Only 33% were accessing social assistance, not specific to TB, but any form of social assistance. Could have been an old age grant or anything to that effect. And 6% were reported receiving food parcels. Also important to note that these are the same patients who had a high unemployment rate, higher than the national average at the start of treatment. And by the end of treatment, their unemployment had increased from 48% to 68%, which is quite significant, further perpetuating the position that they would find themselves in with regards to food insecurity. And in the study, we also looked at social consequences, which is the bar graph at the bottom. And of the social consequences, social exclusion and food insecurity actually came up quite highly among both DR TB patients and drug-susceptible TB patients. And then furthermore, just to highlight that, yes, we're looking at catastrophic costs, which found that 56% of all our participants, or all our patients rather, had or were facing catastrophic costs due to TB, meaning they were spending 20% or more of their annual household income now on TB. So one of the things to note is that direct medical costs were low. Of course, treatment is generally free in South Africa, so the bulk of the cost was not on that. However, a lot of the costs were driven by indirect costs, which is income loss, which I've already spoken to in the previous slide, but also by the non-medical costs, which includes transportation, accommodation, food, and nutritional supplements. And we actually found that out of these direct non-medical costs, patients were spending the most on nutritional supplements. So this talks to a need or something that is happening in the community where people do see a need for nutritional supplements and do spend money, significant amounts of money on nutritional supplements. Colleagues may have seen the South Africa Food Security Index, which was published last year. And just to put this into context, it's yes, our TB patients are having quite a huge challenge with food insecurity, but it is actually a national challenge where we have seen our food security index dropping from 64.6 in 2018 to 45.3. So South Africa, we could say, is less food secure than it was a decade ago. And some of the contributing causes that are cited are around food inflation, personal debt, climate change, drought, those conditions as well. And as well as sometimes global supply stocks and how that has, I guess, impacted the cost of food. And 1 in 4 households were now consuming a less variety of food due to these economic constraints. And I mean, there's a lot of data that was really published, but I think if you look at the bottom left, just to see that 1 in 4 children in poor households were stunted due to chronic hunger and poor nutrition. So yes, again, to say that it is a national challenge. Even though it is affecting our TB patients, it's not happening in isolation. So colleagues, just to draw attention to the fact that malnutrition and TB are just this vicious cycle where patients might be at risk of TB due to the fact that they are undernourished, they are experiencing undernutrition. And what would happen is that they would have a higher likelihood of progressing from latent infection to active disease. And of course, their immune system might be even weaker. They would also then have an increased risk of mortality for those that have a low BMI, like we've highlighted. And of course, food insecurity and poverty are known to prevent people from seeking diagnosis, adhering to treatment, and even just initiating treatment. If we look at the patient pathway at the bottom, you may see, let me just try to do, sorry, pointer. Okay, you may see malnutrition sitting over there. And of course, where it's impacting most is that transition from infection to active disease. Also, just to note that when patients then or have TB, they may have reduced appetite and an inability to take food, further impacting their outcomes. They may also have a decreased ability to absorb nutrients. And so it just becomes this vicious cycle that patients are then stuck in. And then with regards to the impact on TB outcomes, we do know it's well documented that undernutrition is affecting treatment success. So there is a lower treatment success. And in one of the studies conducted in India, I think, it reached as high as 25 to 35% lower treatment success rates. And that makes you think that if this is something that would be addressed, how well it would improve treatment success rates. With regards to mortality, 2 to 4 times higher risk of death has been documented. And with a country like ours, where we're really struggling to reduce mortality, TB mortality, this is something that could really impact our outcome in that regard. Undernutrition also increases the risk of treatment failure in general, and also relapse rate. This is specifically with those who had a low BMI. In a study, they were recorded as having double the risk in terms of the relapse rate as compared to other patients. Undernutrition is also known to affect or impact your sputum conversion time, the loss to follow-up rate, which is documented to be 20 to 25% higher in undernourished patients. And I did touch on it, on how these patients are less likely to adhere to treatment. And of course, then they may experience worse drug toxicity or worse adverse reactions to drugs. This could be as high as 30%. Borrowing a slide from the Department of Health, which looked at DRTB patients from their 2021 data in EDR Web, they also saw that outcomes were impacted, and those that were underweight had adverse outcomes. And if you look at the success rate, it decreased from 69 to 59% in those who are underweight. The death rate was higher from 12 to 16%, and the loss to follow-up rate was also higher. So this is also just talking to the data that's already out there on how outcomes are impacted. Currently, the country does have some interventions. There is a national policy on food and nutrition support. There are guidelines. They are a bit dated, but there are guidelines on nutrition, specifically in HIV/AIDS, TB, and other chronic debilitating conditions. There are also other TB guidelines and policies. However, where the gap has really been in scaling these guidelines up and these services that are meant to be available, and also ensuring that they're integrated within TB care. So yes, there are some guidelines and policies that have been available. However, I think we faced some challenges in integrating those and ensuring that they're optimally implemented. Going back to my slide on, or that pathway, unpacking that pathway that I showed earlier a little bit more, just to highlight that really the patient pathway in a patient who's exposed to TB, or in someone who's exposed to TB, right up until their outcomes, is influenced by so many factors, including malnutrition and food insecurity, but it goes beyond that. And I touched on some of those issues around, how even climate change has impacted food insecurity in South Africa, and how this can therefore not be a health issue, but is really a multi-sectoral issue. And it's something that we need to have a multi-sectoral approach towards. So yes, there's one aspect where we will have our interventions from the medical side. We will have interventions even maybe from the nutrition side, maybe through other sectors like DSD, etc. But there's really a broader picture or a broader approach that we really need to take if it's something that we are really going to tackle. So that said, WHO does have guidance on a multi-sectoral accountability framework for TB, and the country has adapted this for itself. And we do have a document for the country on what this multi-sectoral accountability would look like for us. And really, this is looking at making sure that social development is on board, agriculture is on board, and if we take it a step further, even housing, private sector, etc. And this is really just talking to addressing these issues that I have mentioned in the previous slide that are contributing to those who are exposed becoming infected, those who are infected developing active disease, and those who have active disease really having either optimal outcomes or adverse treatment outcomes. So I'm going to hand over to my colleague Annabel, who's then going to take us through what is then in the WHO guidance on TB and nutrition. But before I do that, just to say that I really think as we look forward, we really need to, I hope, coming out of this and out of the discussions that will take place after this, really have almost like a roadmap of how we're going to tackle this in a multi-sectoral manner, because we really can't talk about ending TB, tackling mortality, really improving our outcomes to where we want them to be without tackling this issue of malnutrition and even other determinants. This is a quote from the Standerton study that I mentioned earlier, and I really liked it. Oh, sorry, my apologies. It's from one of the studies, not the Standerton one, but it really just said that undernutrition fuels the TB epidemic in silence. So there's all these things that are happening in silence, under the surface, that they're really, really driving the epidemic, and we can't afford to continue to ignore them. So with that said, I will hand over to Annabel.
Right, can you see my slides?
Yes, we can.
Great. Okay. So thanks very much. That was a brilliant introduction, and thank you very much. And that gives me a chance to whip through some of the slides that I have that may be a little bit of an overlap. So I'll just give an overview of the upcoming guidelines, which have been developed. They've actually gone through our process and been cleared by the Guideline Review Committee. So we hoped that the guidelines will be out in June. They're currently being laid out. So we've seen this. This is actually the global vision. So we've gone in to South Africa and now we're going out to global. And you can see undernutrition is the big driver globally. It accounted for close to 1 million TB episodes in 2023. And you can see from this map below the percentage of TB episodes attributable to undernutrition. And the red hotspots are where undernutrition accounts for more than 8%. So South Africa is not quite there. Last year, WHO commissioned a Cochrane review, which estimates that undernutrition doubles or more than doubles the risk of TB. And a review by Lee et al. Found that the prevalence of undernutrition amongst people with TB was almost half, which is around the size of the problem which Nkateko showed for South Africa. And of course, you know, the bidirectional relationship, Nkateko very articulately outlined this. Just wanted to highlight a couple of studies. There's one, a prospective cohort study by Sinha et al. That found that this was amongst 2,900 patients, found that unchanged or decreased BMI was associated with a 5-fold risk of mortality. And a nested cohort within the rations trial by Bhargava et al. In India, in Jharkhand, found that weight gain, particularly within the first 2 months of TB treatment, was associated with improved survival or reduced mortality. And we know that obviously TB can lead to and worsen undernutrition, and as we've seen, patient cost surveys around the world have found high proportion of catastrophic costs due to food and nutritional supplementation. So nutrition is firmly embedded within the NTB strategy, within integrated patient-centered care and prevention, Pillar 1. Of course, Pillar 2 is really critical in terms of working across government, bold policies and supportive systems. And Pillar 3, of course, for intensified research and innovation, for fine-tuning delivery. At the United Nations General Assembly high-level meeting in 2023, member states committed to assuring integrated prevention, screening and care for tuberculosis and comorbidities within primary healthcare. And they also committed to developing robust national strategic plans, ensuring that this was possible. So back in 2013, WHO produced its first guideline on nutritional care and support for patients with TB. And since then, there's been new evidence. And so WHO commissioned systematic reviews on 3 PICO questions, namely focusing on nutritional interventions for people with TB, that's macronutrient and micronutrient, micronutrient supplementation alone for people with TB, and food assistance to household contacts of people with TB. TB. We also commissioned surveys amongst Ministry of Health participants, as well as interviews with people who've had TB in their household contacts to assess feasibility and acceptability of nutritional interventions. And a guideline development group, or GDG, was convened in June to July of last year to review the evidence and formulate the recommendations. So for PICO-1 on nutritional interventions for people with TB, the systematic review identified 17 randomized controlled trials, which measured the impact of the following interventions on one or more critical outcomes. And I'd just like to say the evidence out there is that the trials tend to be quite small, so that limited the ability for meta-analysis, and the outcomes were very diverse. So it's, it was very much a case of looking at the evidence overall. Now you can see the interventions range from arginine-rich food, high protein, high energy protein food, which you would imagine, as well as financial support, through to green tea extract, trana striata, and dietary nursing. And the GDG reviewed the data and felt that the balance of effects for the studies on green tea extract, fish oil, trana striata, and dietary nursing was uncertain, whereas so they really judged that the evidence did not support the provision of these interventions for people with TB. Whereas for the other 4 interventions, arginine-rich food, high energy protein food, financial support, and psychosocial counselling, as well as food vouchers, they felt that the balance between benefits and harms probably favoured the intervention. So here you can see on the left is the interventions as well as the outcomes, their impact on those outcomes, and the study authors, as well as the effect size on going to the right, and certainty of evidence. So you can see that the various interventions had an impact on cure, treatment completion, as well as nutritional outcomes and functionality measured by grip strength. There was one study by Martins that found that adherence was not favourable, and this was because during the intensive phase of TB treatment, the patients were asked to come into the health facility and eat their food in the health facility. The trial was actually accompanied by a qualitative study that demonstrated that the patients felt that they felt shy about coming into the health facility and eating there, and they also found that it was inconvenient. So this was discussed by the GDG, and they felt that this wasn't a reflection of nutritional support for people with TB on their impact of adherence. It was more a reflection of the poor design of the study, and really highlighted the importance of tailoring your study towards the needs of the patient and being sort of flexible and people-centered effectively. So the second PICO question on micronutrients for people with TB, the systematic review identified 33 randomized controlled trials on single micronutrients, vitamin A, D, selenium, and zinc, and 17 on multiple micronutrients, being single administration of 2 or more single micronutrients. Now, none of the studies investigating vitamin D, selenium, zinc, and multiple micronutrients demonstrated a balance between the benefits and harms in favor of the interventions for many of the critical clinical outcomes, other than for an increase in serum levels. So the GDG didn't really feel that, well, they judged that a recommendation would not be appropriate for these particular vitamins. However, reviewing the data on vitamin D, they felt that the balance between benefits and harms overall probably did favor the intervention. And we can see here the studies on vitamin D and the impact of vitamin D on TB cure, adverse events, and change in serum levels. And the GDG very much focused on the cure, and they noted that there was a very, particularly with meta-analysis of the 2 studies, there was quite a high impact on cure. However, the two studies were designed very differently, and one focused on it was in Egypt in a population of high vitamin D deficiency prevalence, whereas the other study in China was focused on a population who had tested for vitamin D deficiency and were found to be deficient. And also the vitamin D dosage was very different. So there were a couple of outstanding questions on that, but you can see there's a reduction in adverse events, but no impact on any other TB treatment outcomes, and a change in vitamin D, an increase in vitamin D serum levels. Then finally, for PICO3, which is food assistance for household contacts, a systematic review identified one randomized controlled trial, which was conducted in Jharkhand, which is a food insecure area in region in India, and it was conducted amongst more than 10,345 household contacts, and they were provided with food baskets which with 750 calories and 23 grams of protein a day, as well as one recommended dietary allowance of micronutrient pills. And this was given for the duration of TB treatment. For DSTB, it was just 6 months, and for drug-resistant TB, it was for a year. And this found a reduction in TB incidence of close to 40%. So the GDG very much judged that the balance between harms, between benefits and harms, was favored the intervention. So as a result of this GDG process, we are coming up with the following recommendations. They are in press at the moment. A recommendation that has been sort of adapted and agreed upon as it came from the previous guideline, which is based on indirect evidence, because it's quite difficult to measure the impact of assessment and counselling on nutritional outcomes or the TB treatment outcomes. So it's been reworded from the 2013 guidelines. At diagnosis and throughout treatment, all individuals with TB should be offered nutritional assessment and appropriate counselling based on their nutritional status. That's a strong recommendation. And then we have new a sort of update, because household contacts were recommended screening and assessment, but this recommendation recommends that all household contacts of people with TB should be offered nutritional assessment and counselling as part of contact tracing. If undernutrition is identified, it should be managed according to WHO guidance, and that's strong recommendation, low certainty of evidence. And then new recommendation, which is a much more expansive recommendation than the previous guidelines. Nutritional interventions should be offered to individuals with TB who have severe, moderate, or mild undernutrition, which is BMI of less than 18.5, as part of comprehensive package of TB care. Strong recommendation. And then the next strong recommendation is in settings with food insecurity, food baskets in combination with multiple micronutrient supplements should be offered to all households of people with TB. So that's really keeping to the same situation as in Jharkhand province in India, in food insecure settings. And then for vitamin D, we have a conditional recommendation that it should be provided to people with TB in the context of rigorous research. In other words, in order to find those outstanding answers to those outstanding questions. And I just want to flag also that the recommendations, so these recommendations replace the previous guideline, and just like to flag up that there was a recommendation in the previous guideline that multiple micronutrients should be offered to people with TB who are eligible for nutritional support, but it is not available, they should be given a multi-micronutrients instead of that. So that is no longer, the guideline development group felt that was not applicable, and so there is no recommendation on multiple micronutrients. So that covers that. Just to say that the consolidated guidelines is consolidating other recommendations as well, which relate to TB and nutrition. So we still have the TB screening in people with a risk factor of TB being malnutrition or undernutrition, who are seeking healthcare in settings where the TB prevalence in the general population is 100 per 100,000 or higher. So that means screening in nutrition centres and feeding centres, and also TB screening amongst subpopulations with structural risk factors. Of course, Nkateko's great sort of diagram of the SDGs and how all the determinants feed into, food insecurity is, of course, a structural risk factor for TB and a higher determinant. And so this would probably relate to, I don't know, nomadic people or people in urban settlements, in informal settlements, so of slums or whatever. And then there's, of course, we've taken from the consolidated guidelines for tuberculosis on tuberculosis care and support, the recommendations on treatment adherence interventions for people with TB, regardless of their nutritional status, including material support, which includes meals, food baskets, food supplements, or food vouchers. So we are developing an operational handbook, and we are conducting a survey amongst nutrition and food assistance organizations and departments within in countries. And so it will be going out. It has gone out to, I think, South Africa. It's about to go out. And we will also be conducting a stakeholder consultation for the development of the operational handbook. But key considerations are, obviously, as Nkateko mentioned, multi-sectoral engagement is critical throughout, from planning all the way to monitoring and evaluation. And countries will really need, for assessment of undernutrition and food insecurity. And this also hits the side where it's TB screening amongst people who are food insecure. So, this multi-sectoral engagement is absolutely critical from both sides of the entry point of care. So there'll be a need for mapping of food insecurity, understanding who does what. And this is really critical for budgeting, as particularly as we've got reduced resources now for TB. If the equipment isn't there already, then equipment needs to be included in the health facilities. Models of delivery for assessment and counselling need to be developed. Should it be in the facility, community-based? Of course, training and standard operating procedures should be included. And within the standard operating procedures, obviously, there's the reasons for the other reasons for undernutrition, including HIV, helminth infections, and then, of course, there's the counselling content. And I think studies have found that there's no really standardized approach where in countries where this is happening. So, standard operating procedures are really critical for this. Another thing that came up in the review of the evidence was there's quite a lot of food sharing that goes on. So if a person with TB is given nutritional support, they tend to sort of give it to the children or whatever. So there is a need to frame the nutritional interventions as a medical intervention. And then for nutritional interventions and food assistance, of course, the type of food support will need to be tailored towards the nutritional status. So the options are formulated food, perhaps, ready to use therapeutic foods for those who are severely undernourished, and then maybe just food supplements or food baskets or financial support. And a lot of organizations like WFP are going towards providing financial support, but that how much needs to be considered. Is it enough to provide the right amount of food for that family? And then, of course, patient-centered delivery, talking to that study which found reduced adherence. So there's a need to, to maximize convenience for the people with TB and to minimize stigma, of course, as well. So these are really my conclusion slides. So watch this space for the operational handbook, and the implementation, of course, is going to require a huge amount of multi-sectoral engagement and extensive partner collaboration. But please, please, please consider this as a critical, essential item for TB care, and not something that is a nice to have, which gets kicked out as a result of your needs for prioritization within the funding. So here's the knowledge sharing platform. If you don't already know it, I'm sharing these slides with you, and you can see the link there. The guidelines will be coming up, and I'm sure Nkateko will be sharing once they get shared around. But thanks very much, and I'd like to acknowledge my colleagues in TB program, as well as my colleague in the WHO Department for Nutrition and Food Safety. Thanks very much.
Thank you so much to both our speakers. We will now move over to our question and answer session. And we have a question here from Ingrid. She firstly starts by saying this is very encouraging. And then she asks, will undernutrition be diagnosed through BMI or other tools as well?
So that's a very good question, Ingrid, and I'm sure we have the definitions of the standard deviations and the BMI and the age specific height for weight and weight for length. But what there will be recommendations within the operational handbook on the how-tos. So we will be, and there's MUACs as well for particular populations. So we will be providing further guidance on that. But that said, the definitions for those people who are eligible for nutrition will be, those BMIs as well as the weight scores, the Z scores. But I think, obviously, for assessing undernutrition and risks of, whether somebody's on the edge and whether they're going towards, all those need to be considered. And I think what we're trying to do with during our consultation is assessing food insecurity as well. And trying to get a measure of that, because obviously, if a person's not totally undernourished, they may be tomorrow, whatever. And this is something we need to talk about, but we don't really want to overburden the TB programs. That's something one has to think about. So, the question is for food insecurity, is there an easy way of measuring food insecurity with a few questions, which can then be flagged up to partners who are working on food assistance to really follow up on that. So I think, this is part of the consultation, but the operational handbook will certainly have further guidance. Thanks very much.
Thank you, Annabel. Nkateko, would you like to add, or you're all right?
I think Annabel has covered it well, but just to say that the nutrition guidelines that we currently do have, the ones that I referred to for HIV, TB, and other chronic conditions, do also then detail out the use of BMI, but then they, like Annabel said, do specify, populations where you can use MUAC, and the triceps, skin fold, etc. So I think maybe one of the things that I mentioned earlier about the intersection of these various guidelines, I think this is something that maybe once the guidelines are out and the operational handbook is out, we would need to sort of unpack for ourselves to say, what are we expecting to happen in our facilities, practically speaking, you know? Yeah.
Thank you so much, Dr. Mkhondo. I see a comment here from someone from Department of Social Development, and I think it would be very valuable if someone from the department can weigh in on this. So if you're from DSD and you're on the call, please do raise your hand or add a comment in the comment section. We do also have a question from Alison. Alison, if you're able to talk, could you please unmute and ask the question? Alison?
Yeah, hi. Okay, thanks.
Okay.
Thanks. Yes, I can do it now. Hi. Yeah, thanks. Lovely presentations. Thank you. Really interesting. I'm just sorry. This is reminding me that I'm fairly sure that there are some standardized questions about food insecurity, which of course I'm now not going to be able to remember exactly where they are. But I thought there were some. Maybe they're just too long, Annabel. Is that the point?
Yes, no, there are. But weirdly, I mean, because we're talking with FAO at the moment, those food insecurity questions are asked to be asked at household level, but only to make a judgment at national level. And so we are actually, during the operational handbook development, we are going to be trying to whittle down to see if we can keep, just even it's screening for food insecurity. I think FAO is quite sort of quite clear that FIES, which is the food insecurity scale. I mean, there are a couple of other ones as well, but nothing that has been validated at household level for some reason. So food insecurity experience scale is the name of it. And I think, I don't know, we'll try and get a copy and include it in the chat. There are countries that are using it, or a subset of its questions at country level, to make that judgment. And I think that would probably be the easier way and the simpler way to go about it, and perhaps get people from the food assistance organizations to come in and validate it.
Yeah, thanks.
Thanks, Annabel and Alison. I see we have a hand from Masindi. Masindi, you may go ahead.
Thank you very much. Thanks to Dr. Mkhondo and Baddeley for the presentations that they made, particularly around food and security. I think while Dr. Mkhondo was still presenting, I made a comment to say, indeed, as the Department of Social Development, we are on board because we are noting, the role that food and nutrition play on TB patient. I must also indicate to the team that we are blessed because we are receiving support from the NDOH and the World Health Organization in ensuring that our professionals, which are the social services professionals in provinces. This starts from your social workers, your community development practitioners. The services that we are rendering around food and nutrition are no longer just rendered, but we are linking them with the TB outcomes. You would know that we're having different facilities that are ensuring that meals are provided to beneficiaries on daily basis. But because we were less involved on TB, but focusing on HIV, we did not really have indicators that speaks to the beneficiaries who are having TB. But, we are starting and we are in the process of making sure that, we are institutionalizing TB in the department so that, we are then in a position to start linking all the SRDs, the catastrophic cost issues, all the efforts that we are taking on ensuring that beneficiaries are, we reducing poverty. Now going forward, I think later, because I've seen a comment, you know, when I was joining this team that, you know, at a later stage, maybe as the department, we can still come and present to this team to say, this is the progress that we have made in ensuring that we are contributing to the TB outcomes. But definitely we have just started the work, and I believe in due time, we are going to be in a position to report the progress that we are making as the department. But indeed, a lot is happening on the ground. It's just that it was not integrated with TB services. So it's our role to ensure that whatever that is happening now, you know, it's now linked to the TB space. You know, those that are getting grants, we need to make sure that we know if they have TB or are coming to our centers. You know, that is the kind of work that we are starting to embark on as the department. So basically we are in and just make sure that if there are anything that talks to and involve us so that, you know, we can also start working together with everyone. But thanks to WHO and NDOH for the support that they have started, you know, providing us as the department in ensuring that we just bring the work that we are doing together so that it can now speak to the TB outcomes in the country. Thank you.
Thank you so much, Masinde, and we look forward to having you on this platform in the near future. We have a question from Bongiwe. Thereafter, I'll go to Peter. Bongiwe asks, in the case where malnutrition is not a concern and only TB and maybe food insecurity, but normal BMI, are these patients still required to get nutritional supplementation in addition to food parcels?
That last bit confuses me, but yes, I mean basically if a person has a normal BMI and their household or they on their own are seen to be food insecure, the household, so the recommendation on food baskets for households of people with TB includes the person with TB, basically. So if a person with TB is not undernourished, but the food is the household is seen to be food insecure, then the patient will of course be receiving food support. And I think the whole the couching of the guidelines is about the family, the vulnerability of the family and the person with TB, and it should be sort of seen as together. It's not just one, you know, just food for the TB patient. It should also be food for the family, because everybody benefits. That's better for the food sharing as well. And yeah, so that person would be. Now the question is, because the evidence is out there as far as the benefits of multi-micronutrients for people with TB, but because the rations trial included multi-micronutrients as part of the food basket for households for preventing, we're saying to countries, you decide whether you give the patients multiple micronutrients, but the evidence doesn't necessarily doesn't support it and doesn't go against it. So that's the situation. We just don't want, you know, sort of limited funding to be used in the way that, you know, to be wasted, basically.
Thank you, Annabel. Peter, you may go ahead.
Thank you very much. My question on the chat box has been answered, but I just have thought of another one. The issue of where there are limited resources, do you think we would have better outcomes? We'll still have better outcomes if the patients who are underweight are given food during the intensive phase, are part of the continuation, and once they have gained weight and also have stabled, then they can be left out now to fend for themselves? Or do you suggest that they should continue throughout the treatment, all the treatment for the 6 months or so?
Listen, the evidence was quite broad and sort of, you know, very small studies and very different approaches. So there is no evidence to show that food nutritional support during the intensive phase only versus throughout treatment is I mean, you know, what benefits would be. But I think, you know, if a person is undernourished, they, you know, it's a right to have food, right? It's a right. So that needs to be addressed as far as undernourishment is concerned. Maybe I think if the person becomes nourished, and as a result of a combination of treatment and their nutritional support after the first 2 months, then, you know, I think, you know, it's something that you need to decide. For planning, it's probably quite tricky, but yeah, I mean, that's something I think you could, it's actually a good idea. It's something for future research, I would say. And I'd be happy to understand what other people think about that question, because that is quite a tricky one in terms of the available research, the available evidence.
Thank you, Annabel. We have a question here that asks, what's the biggest gap in addressing the TB and undernutrition link in South Africa, and what are the next steps or actions needed to make a difference in this area?
Maybe I can jump in there, Nolwazi. I think, like I mentioned earlier, you know, the guidance has been there, but the implementation has really been suboptimal. So I think one of our biggest gaps is around the implementation. I do not want to speak for the nutrition side because I don't know what are the exact challenges that are being faced from that end with regards to implementation, but I know anecdotally it's that sometimes the availability of some of the things that are required to implement these guidelines are sometimes not available at the facility level or where they are needed. So I think, like I said, I think we need to almost like regroup on this issue of nutrition as for the TB patients, but I think just generally, even at a more national level, just to regroup a bit and say, okay, what do we really need to implement this? Which stakeholders do we need on board? I mean, I know previously we had great programs in the communities on food gardens and other community nutrition programs that for the most part have fallen away. So almost like I'm saying, just to regroup, have everyone that we need around the table. And I mean, I just must say to Dr. Masindi, she's like, yeah, I think if I had to write a case study on what multi-sectoral engagement and contribution and accountability looks like, DSD has really been on board, and they are really pushing on their end to say, look, we want to contribute to the TB response, and you know, they've identified ways in which they could do that. But to say that that's what we need to do for even other sectors, we need agriculture to be coming on board to say, look, what can we do? We need maybe even private sector and just even other sectors. I think for as long as we make it something that is solely on the Department of Health, we're really not going to get far, and we will continue to have some of these gaps that keep coming up as we try to implement the guidelines. So I guess in sum, what I'm trying to say is we can't implement these guidelines on our own as just health. It really needs to be a multi-sectoral effort.
Thank you so much, Nkateko. Mohammed, are you able to speak to your question and comment? Mohammed? Okay, I think I'll just read it out. He starts by saying that undernutrition is very important to discuss when one is talking about TB, but he feels that it's always been ignored in TB programs. His comment is that World Health Organization and global funds should establish a sophisticated program on nutrition also, and not only TB treatment and prevention. Would you guys like to respond to that?
I think, I mean, I'll respond as best I can. You know, TB programs are facing big funding cuts, as are HIV programs. The Global Fund is looking to really massively cut support to countries, I'm afraid. This is where math hits the road. This is where you need, as Nkateko has been saying, this is where you need to really reach out to people within the other departments within the government to support. And I think part of this is, maybe it's investment of link people for math and ensuring that that TB becomes a marker for poverty and eligibility for those households for receiving support from the government in terms of social protection, social assistance. This is just one part of social assistance, actually. When we're talking food assistance, and actually, just another thing is, TB. Nutritional interventions for a person with TB should be considered as treatment. It's a type of it's a nutritional intervention. It's therapy. But for prevention, I think we've articulated it as food assistance. We've done that on purpose because we need to get food assistance organizations to think TB and food assistance together. This cannot just be the TB program working alone on its own on this. It has to be across the government, and it has to be across organizations that are working. And there are a lot of organizations out there who are getting support from Catholic Church or whatever, who can, they provide opportunities. And so we need to sort of work closely. And I think that probably means that we need to invest in those linkages much more, and ensuring that there's follow-up. And I noticed in the chat, what happens after TB treatment is finished, what happens to the household if they're food insecure. Well, I think that is important. It has to be part of a continuum. Just like for HIV, what happens when TB treatment finishes needs to carry on in the HIV services, or the diabetes, the NCD services. So I think, it's all about linkages to care and linkages across government. And it's, math is the answer, I think. But thanks. Good questions.
Thank you so much, Annabel and Dr. Mkhondo. Please do join us next month, where we will be having Prof. Novel Shego, who will be speaking on biomarkers for tuberculosis from discovery to translation into point-of-care tests. And I'd also just like to remind everyone in attendance that if you'd like to see yourself on this platform, please do email myself at ngozi@tbthinktank.org. Before we end the session, I also would like to remind everyone about the TB Think Tank membership questionnaire, which was sent around 11. Please do take just 3 minutes out of your time to complete the questionnaire, as it will help us update your contact information and align on our priorities and bring in new voices. With that said, I'd like to thank our 2 speakers for today. Thank you for your time and the insights, and thanks for everyone in attendance as well. Thank you so much and enjoy the rest of your day.
Thanks,
everyone. Bye.
Thanks so much. Bye-bye.
Bye, everyone.